Watch the acute stress response spike. Cortisol floods, thinking stops, aggression surges.
Imagine being a solitary predator, hardwired to rely on stealth and vertical escape to survive. Then you are placed inside a hard plastic box, transported in a rumbling vehicle, and extracted into a loud, brightly lit room. Veterinary practice involved tipping the carrier up and unceremoniously dumping the animal onto the table, or dragging them out by the scruff of the neck. Those actions guarantee a violent spike in panic. Modern practice dictates the carrier door assessment. Place the carrier on the table, open the door gently, and take a physical step back. Because of this rapid physiological cascade, the most critical diagnostic data is gathered right now, before a hand ever touches the patient. Forcing physical contact immediately guarantees a traumatized subject, rendering accurate medical assessment nearly impossible. To get accurate vitals, the environment has to change. The metallic table is cleared of clutter. A synthetic analog of the feline facial pheromone, the calming scent cats leave when they rub their cheeks on furniture, is diffused into the air. Most importantly, providing an elevated perch gives the cat the security of high ground. Once the carrier door is open, the clinician initiates the 3-minute rule. For 3 to 5 minutes, the veterinarian team ignores the cat. Direct eye contact is avoided entirely, as felines interpret it as a direct threat. Instead, the clinician takes the medical history, allowing the cat to voluntarily map the room. This spectrum categorizes 3 behaviors: the explorer with a high tail, the cautious crouched turtle, and the terrified bunker. Zooming in on the bunker, we look for rapid flank breathing exceeding 40 beats per minute and piloerection. This categorization serves as a strict diagnostic triage, dictating whether a physical exam can proceed without compromising safety. There is a dangerous trap in veterinary medicine. A clinician looks at a cat sitting perfectly, completely motionless on the exam table, and assumes they have a highly compliant, calm patient. In reality, that stillness is often learned helplessness or tonic immobility. This is an evolutionarily conserved passive defense mechanism. When an animal decides fighting is useless and escape is impossible, their brain flips a switch to freeze, hoping to minimize damage from predators. This matrix illustrates the difference. True compliance features pliable muscle tone. The cat practically melts, paw pads visible. Learned helplessness features muscles pulled tight as a coiled spring, paws tucked underneath. The cat endures until a threshold is crossed, like a needle stick, triggering defensive aggression. Recognizing the red zone before that explosion requires reading microsignals. If whiskers suddenly bunch forward into an offensive pucker, a bite is coming. The true red zone signal is the tip twitch. The tail is perfectly still, but the final 2 centimeters flick rhythmically, building kinetic energy. The most counterintuitive warning sign of all is the pre-strike silence. When a cat that has been steadily growling or yowling suddenly goes dead silent and freezes, they have decided that vocal warnings are ineffective. Physical violence is the very next action. If any of these signals appear, the veterinary team must initiate the safety stop protocol. The handler clearly vocalizes stop, slowly releases any physical pressure on the cat to let them right themselves, and the team pivots to chemical restraint, like injectable sedation. Misinterpreting terror-induced paralysis for calm compliance is the leading cause of preventable human injury and patient trauma in the clinic. Heavy restraint inherently triggers a fight-or-flight response. We use the mechanics of the touch gradient. You initiate contact in a neutral zone, like the shoulder. Then you maintain continuous contact. Taking your hands off and putting them back on causes repeated startle responses. Instead, you glide your hands over the body to the area of interest. This diagram breaks down the modified scarf wrap, which replaces the painful, outdated practice of scruffing the cat's neck. By wrapping one side of a towel under the neck and the other across the chest, the clinician provides calming compression and protects themselves from claws, while leaving the rear of the patient completely accessible for taking a temperature or giving an injection. The ultimate tool for de-escalation is engaging the cat's parasympathetic nervous system through a deliberate, mutual slow blink. If the cat makes eye contact, the clinician slowly closes and opens their eyes. If the cat returns that heavy-lidded blink, their heart rate is dropping and the exam can safely proceed. Failing to use these low-stress methods ruins the medical data. A terrified cat will yield a stress leukogram, an artificially skewed white blood cell count, and present with psychogenic tachycardia, a stress-induced rapid heart rate that masks true cardiac issues. Applying these observation techniques provides the clinician with rigorous, objective data.
In the high-stress environment of a shelter or a clinic, a quiet cat is often treated as the ideal patient. We tend to equate this silence with calmness, a baseline assumption that dictates how most people approach and handle them. This assumption leads to the somatic trap. It's the mistake of judging a cat's emotional state entirely by obvious voluntary macro movements, like walking toward a person or purring, while missing the tension hidden beneath the surface. But cats present their signals in a rapid, often contradictory symphony. True fluency requires looking past isolated body parts to read the syntax of the whole animal, a process known as Gestalt assessment. This assessment relies on the Triad of Assessment, which monitors 3 channels simultaneously. The somatic channel tracks voluntary posture, the autonomic channel observes involuntary physiological reflexes, and the kinetic channel measures the fluidity and velocity of movement. Relying on just one of these channels creates a false sense of safety. When we only see the posture but miss the underlying physiological arousal, we end up misinterpreting a cat's intent, leading to preventable injuries and high-stress encounters. Consider a cat in a shelter intake ward, resting perfectly still in her litter box. She doesn't hiss or attempt to flee when the door opens, leading staff to describe her as quiet and easy to handle. However, her autonomic signals reveal a different reality. Despite the ambient lighting, her pupils are fully dilated. Her respiratory rate is shallow and exceeds 60 breaths per minute, indicators of intense internal arousal. Then there is the postural compression. Her limbs are tucked tightly beneath her, her head is held below the line of her shoulders, and her whiskers are retracted flat against her cheeks to make her presence as unobtrusive as possible. This isn't relaxation. It is tonic immobility. In the wild, freezing is a last resort survival strategy to avoid triggering a predator's visual tracking when escape is impossible. Forcing interaction with a cat in this state violates a critical boundary. Because they have already reached their internal limit, they are at high risk for explosive defensive aggression if they are pushed even slightly further. It's a common scenario in the consult room. A cat initially bunts the technician and purrs, but then suddenly bites when a stethoscope is applied or abdominal palpation begins. These transitions to aggression are rarely as sudden as they appear. The signals of escalating conflict were being broadcast by the cat. They were simply missed by the person handling them. The first warning sign of rising overstimulation is often found in the tail. While the tail may stay upright, the distal 1/3 begins to flick or twitch spasmodically, signaling a shift in autonomic arousal. This is followed by secondary microsignals, a subtle rippling of the skin along the spine, and a lateral rotation of the ears into an airplane wing position. The cat has shifted focus from interaction to defensive monitoring. To prevent this escalation, we use a 3-second rule. By limiting touch to short intervals and pausing to see if the cat solicits more attention, we perform a vital consent check. Responding to these subtle shifts in the tail and ears allows us to treat a cat's behavior as a direct request for space, preventing the need for the animal to use its teeth to be heard. When a senior cat becomes increasingly irritable or aggressive toward a new kitten, it's often dismissed as a behavioral change. In many cases, this grumpiness is actually a response to chronic physical pain. To differentiate pain from fear, we use the feline grimace scale. Pain manifests as intense orbital tightening, a squint, and a flattened muzzle, differing from wide-eyed fear. Finally, cats with spinal pain often hold their neck in a rigid, extended line from spine to head. Cats are evolutionarily programmed to mask physical weakness to avoid predators. Recognizing these specific markers allows us to identify when aggression is being used as a protective shield for an underlying medical crisis. The next step in feline medicine involves automated ethology. We are now seeing the development of artificial intelligence models designed to constantly monitor hospitalized or sheltered cats for these very signals. This technology uses computer vision to map facial landmarks in real time. By tracking changes in ear distance or eye aperture, the system can alert clinicians when a stoic patient's pain score exceeds a specific threshold.
While AI provides objective data, experienced practitioners rely on thin slicing, the ability to find patterns in narrow windows of experience. Feline fluency turns a stressful encounter into a predictable interaction. It ensures that fear and pain are identified the moment they appear, providing the necessary intervention for cats that would otherwise suffer in silence.